Okay, so good afternoon, everybody. Thank you for joining. I will now start sharing my screen. So good afternoon and welcome to this 9th webinar in the series that we organized together with the European Academy of Neurology and with the European Reference Network for Rare Neuromuscular Diseases. Today's topic is ultrasound diagnostics for cervical dystonia, and it will be presented by Tobias Bäumer from the University Lübeck in Germany. I will just give you some general information about the webinar. So these webinars are on rare neurological, neuromuscular, and movement disorders. And we will have a 30 to 35 minutes presentation. And at the end, we will have a 15 minutes Q&A session. So you can write your questions in that section, which you can find the button in the lower toolbar. And of course, if you have general questions, please write them in the chat. So our target audience for these webinars are neurologists, residents, pediatric neurologists, geneticists, and other paramedical personnel, which is involved in patient care. And as I said, we are recording these webinars, so we will put the webinar on our website at the latest 2 weeks after today. So this is the link for that, but I can share it also in the chat afterwards. And for more information on this disease group, we have collected some documents which you can find here. So disease knowledge for the disease group dystonia. At the end of the webinar, your browser will automatically open satisfaction survey, so it should take 2 to 3 minutes only to fill it. So I would like to ask you to fill that survey because it gives us a precious feedback on what you think about the webinars and how we can improve them. And some words on the European Reference Network. So I work for the European Reference Network for Rare Neurological Diseases. We are coordinating that from here in Tübingen, University Hospital Tübingen, and I'm the training manager here. And as you can see, this network is a group of expert centers around in different countries in Europe. We have full members in those countries with a dark blue and affiliated partners in the countries with light blue. And all of them are having expertise in a special disease group. We are covering those 6 disease groups, and through those networks that the European Commission has created, we are trying to intensify our collaboration, and to, of course, the last goal is to provide better care and timely diagnostic for the patients. Okay, so today I am happy to welcome our speaker, Tobias Bäumer. He is currently head of the experimental neurophysiology group at the Institute of Neurogenetics at the University Lübeck in Germany, and head of the Dystonia clinic. He received his training at the University of Hamburg in the field of experimental neurophysiology of the motor system in health controls and patients with movement disorders. He had been a research fellow at the Department of Neurology at the University Medical Hospital in Hamburg from 1996 to 2006. And from 2006 to 2013, he has been consultant in the Department of Neurology at the same hospital. And from 2013 to 2020, he has been head of the laboratory of the research group Movement Disorders and Motor Physiology, and as well a head of the outpatient clinic for botulinum toxin treatment. His scientific focus is on connectivity and plasticity in the human motor system. and his clinical focus is on adult and pediatric movement disorders and diagnostic of peripheral nerve diseases. He has 95 peer-reviewed articles and 6 reviews. So I'm very glad to have Tobias Bäumer here for today's webinar. Thank you for accepting our invitation, and we can start. So I will stop sharing my screen.
Okay, now I'm on the screen. First of all, I thank you, Sanja, for inviting me for this webinar, and which is on the topic of ultrasound for cervical dystonia. And just for my person, where is Lübeck? Okay, Lübeck is in the north of Germany, and sorry. Okay, and my topic will be mainly on cervical dystonia. And here are 2 typical examples of patients with cervical dystonia with a rotation of the head. And also here on the other side. What you see here is not a pure cervical dystonia, but a segmental dystonia also involving the arm. But in my talk, I will focus on the cervical findings and symptoms. So, okay, I'll move on. So my main topic will be on ultrasound guided injections in cervical dystonia and the diagnostic in cervical dystonia by ultrasound, mainly in planning the botulinum toxin treatment. So first of all, I'm curious if you are using ultrasound and how many patients with cervical dystonia you are treating. So I go over to this question, and Sanja, please, can you?
So here is the poll, and you can vote now. Okay, 15 seconds left. Okay. So here are the results.
Okay, so, okay, a few of us are using ultrasound, the majority not. So I'm coming to the next question, which is, how many dystonia patients do you treat with botulinum toxin per week?
Okay, here is the question, and you can vote now. Fifteen seconds left. Okay, so here are the results.
Okay, very interesting. Okay, so my motivation for doing or focusing on ultrasound were clinical factors. So there are some factors influencing the effect of botulinum toxin in the treatment of cervical dystonia. And one thing which is important is if a patient had a head tremor or is of a high age, this patient typically have a bad or a poor outcome after treatment. And also psychiatric diseases and a very severe dystonic syndrome is leading to a worse outcome after botulinum toxin. Side effects, high dosages. Okay, this is self-explanatory, also resulting in a bad clinical outcome. But these are the published data. What could be other factors influencing the botulinum toxin effect? This could be a wrong pattern of muscles to be injected, or a change of the injector, which is closely related to the first factor. And another factor could be that there are deep muscles in the neck involved, which are hard to find and to inject. And this all result in the phenomenon that it's really hard to reproduce an injection protocol just by looking and touching a neck or even doing EMG. So there's a need for a standardizing of a treatment, and how can we do this? So
sorry, Tobias, we have received one message. If you could speak louder, I hear you quite well, but I don't know, maybe you can try. Yeah.
So I can try, I can hold my microphone a little bit closer to my mouth.
Yeah, okay.
Maybe this is better. Okay.
Yeah.
So there are some published data, what we can do for optimizing botulinum toxin treatment. And there's good evidence that a polymyographic EMG analysis, which muscles are involved in treatment-naive patients, helps to improve the botulinum toxin effect. This is also in patients with a deterioration of the treatment effect. But what is known about the ultrasound? This is only one small study where dysphagia disappears after using ultrasound for guidance. Okay, what is about target rates without any guidance? And these are data not related to dystonia, because we do not have this data. But in parallel, we can look at normal anatomy, and these are injections or putting a needle into a cadaver, into extremity muscles. And what was found in cadavers, there was injection using manual needle placement, and then they checked the accuracy by dissecting the calf muscles. And what they found is that there's a target rate, even in large muscles, of about 60%. And this decreases in medium or small sized muscles, especially in the upper extremity, where there's a target rate of roughly about 35% in the target muscles. And if you look at superficial or deep muscles, it's nearly the same, 50% target rate for superficial muscles, which is quite low, and a target rate of about 35% in deep muscles. So what is about the side effects? This is the study which I talked about earlier. This was a study where patients were injected with EMG guidance, and some of them had severe swallowing problems after the injection. And what they did is they used ultrasound for the injection of the sternocleidomastoideus, and these swallowing problems disappeared after using the ultrasound, which maybe is related just to a more superficial injection into this muscle. Okay, what is about other muscles? And this is a study also in extremity muscles, but not in cadavers, but in children with cerebral palsy. And they made a manual placement of the injection needle, and then they switched on the electrical stimulation and looked how often they have to correct the needle. And then they found the following target rates. And for the gastrocnemius and soleus muscle, a big and superficial muscle, there was a target rate of 75%, which is quite well. And also abductors, but even in the hamstring, it goes down to 50%. And for the tibialis posterior muscle, 11%, biceps 60%, and forearm muscles 13 to 35%. And this is real life data in patients. Okay, so maybe it is good to have a guidance at all, but maybe we can use ultrasound. What are the data for cervical dystonia? And there's a very interesting study by Lee and colleagues from 2009, and they had a group of patients with cervical dystonia with a bad clinical outcome after injection. And they did an examination and found that there are deep muscles involved in these patients with a torticollis, and they injected this muscle, which is the obliquus capitis inferior, a very strong rotator by ultrasound. And the patients we suffered very severe from cervical dystonia. It helps quite well to inject these muscles. And in the same year, Gerhard Reichel from Zwickau here published a paper about different components and about rotation of the neck and the head, which is called the Kappa concept, which I'm maybe familiar with. This is based on the concept that mainly the head or the neck is rotated. And just for an example, if the head is rotated, there's even no rotation between the cervical, here this is C2, to the mandibula, and this is C7. And if the neck is rotated, or in torticollis, you have a rotation which is between C2 and C7. And there are different muscles involved in torticaput and in torticollis. At the end, this is just a concept looking at basic anatomy and looking at muscle functions. But what he also did in this study is he looked at side-to-side differences in size of certain muscles, and what to be an indicator to be involved in cervical dystonia. And what he found is a very huge side-to-side difference in cervical dystonia in the sternocleidomastoideus, in the splenius muscles, but also in the obliquus capitis inferior, levator scapulae. So there are a lot of muscles involved, and some of them are not in the typical clinical pattern we used to inject before. So looking at these deep muscles, at this MRI, we have this here, the splenius capitis, the semispinalis capitis muscle, and also the obliquus capitis inferior here in the depth of the neck. And have a look how thick this muscle is. This is a short, but very thick and powerful muscle. Okay, and here there's a vertebral artery, so everyone who is afraid of injecting into the vertebral artery, it's quite here in the front of the muscle. If you try to inject it here in the middle, there's no risk of targeting the vertebral artery. Okay, so what is about now? So a real life example. This is again the head. This is the position of the probe, and you see here the left side muscle. These two layers: the splenius muscle, the semispinalis capitis, and the obliquus capitis inferior muscle. And in the same patient, on the opposite side, you see a huge side-to-side differences in the splenius, semispinalis, and obliquus in comparison. So if you go for injection just by rule of thumb, maybe injecting on the left side here with 0.9 centimeters, you are also in the splenius on the other side. If you go in 1.5 centimeters in depth for the semispinalis capitis, you are directly at the fascia. By chance, it goes to the splenius or the semispinalis capitis. And if you inject the obliquus capitis inferior on this side by 2.1 centimeter, which is exactly in the middle, you will be in the semispinalis capitis. And maybe you may think just by the side effect you will induce by a dropped head here, the obliquus is involved in retrocollis or retrocarpet. So the rule of thumb of injection deep does not help, especially in patients which have a big side-to-side difference. Okay, and here a more systematic view on ipsilateral and contralateral rotators in a patient with a cervical torticollis. Okay, what you see here in blue are the thicker muscles, and even from this side-to-side difference, you can tell in which direction this head is moved. Okay, you have here the right sternocleido, much bigger than the left, and then here on the back, the splenius, which is bigger, and the semispinalis on the opposite side, and again, here on this side, the obliquus capitis inferior, and here trapezius muscle on this side. Okay, these here, these two, splenius and obliquus capitis inferior, are ipsilateral rotators, and these three are contralateral rotators. This is not that clear in each patient, but if you see this, this is a very good diagnostical marker that these muscles are involved in the rotation, and obviously this head is rotated to this side. Okay, so what you can see that ultrasound is not only good for guiding injections, it's also good for diagnostic purposes. And another example, and this lady here suffering from a no head tremor, and she's reporting, oh, the head is moving, it's moving in the no direction over years. And now I'm coming to my third question, and I am interested in which muscles you inject in an horizontal tremor, no tremor. Which is the most involved muscle in your opinion?
Okay, 15 seconds left. Okay, and here are the results.
Okay, this is really interesting, and please hold this slide a little bit. Oh, sorry, it's okay. Okay, the most chosen answer was sternocleidomastoideus.
Yeah.
And this is quite interesting because this is a very obvious muscle because we can see it. And the second choice, choice was the splenius capitis, and this is exactly the muscle which is recommended in treatment of no tremor. And I would like to present a little, and the third is the obliquus capitis inferior. I suggest that my talk to this point maybe bring you to this a little bit to this muscle, but I will present you now a little study we did together with Axel Schramm in Erlangen. So we can switch to the presentation. And what we did is we analyzed the splenius capitis as the proposed most involved muscle, and the obliquus capitis inferior in patient with no tremor. And this is just an example of the EMG data in a patient with a no tremor. What you can see, there are only tiny bursts here in the left splenius and very huge and powerful bursts here in the obliquus capitis inferior. But how can I say that I do this EMG from this muscle. So in the next video shows you my approach, how I do these kind of analysis in my daily practice. This is a video from my outpatient clinic. And you see an ultrasound machine, you see the ultrasound probe and the EMG needle. And I see the muscle in the ultrasound, and I position the needle exactly by the ultrasound. And then I can tell the patient, let the head move, and do the tremor. And then I have at the end, I analyze maybe 8 or 10 muscles, and I have a map of tremor involvement. But in this study we just looked at the splenius and the obliquus capitis inferior to discriminate these two muscles. And what we also did is we analyzed the thickness of the splenius, the semispinalis, and the OCI. And what you see in this figure is that the thickness of this ipsilateral and contralateral is related to the main rotation of the torticollis, because all of these patients had also a rotatory component and not only a dystonic no tremor, that there's not a huge side-to-side difference, which is quite in contrast to the data of Gerhard Reichel. But this study was mainly focused on tremor. And what we found is that the splenius capitis was both splenius were involved in only 8 of these 36 patients. And only 1 was involved in 16, whereas the OCI, the obliquus capitis inferior, both of them were involved in 22 and 1 in 7 patients. And there was no patient in this group where the ipsilateral nor the contralateral OCI was involved. Okay, and if you go a little bit more in detail, when you look at the patients where both OCI were involved, and we look here only at the most active muscles here, the white bars, that there's a huge group where only both OCIs were involved, whereas both splenius, as the only pattern, was present in none of these patients. So this changes my way of treating these patients with cervical no tremor, focusing much more of the OCI and focusing and using this approach with a combined EMG and ultrasound approach for diagnosing the involved muscles. But is it possible just doing ultrasound for visualizing tremor? And in some cases it is possible. Here are 2 examples. Here you see these ultrasound probe position, and you see the tremor here in the obliquus capitis inferior. And it's quite clear that the tremor is in this muscle, and we put a needle into this muscle and we found exactly very high bursts of tremor. But in another patient with nearly exactly the same clinical pattern, the probe is a little bit more anterior, we found that there is a muscle here in front, which is active, but not the OCI, and not the splenius, and not the semispinalis. We didn't talk about this muscle. This is a tiny muscle here in front, which is the longissimus capitis, which is has nearly the same function than the splenius capitis. But for injection, you have to identify this because there's a fascia, a separate fascia around this muscle, and if you inject in the splenius, this will not work. Okay, are there any other reasons to use ultrasound in cervical dystonia? And this is so here you see a patient with a lateral caput, so the head is tilted to the left side and the shoulder is elevated, and the patient had a problem with tingling in the hands, so a thoracic outlet syndrome may be caused by the cervical dystonia. And we injected here into the scalenus anterior and scalenus medius muscle. And you have to discriminate these muscles from the structures of the plexus brachialis, which is here between both of these muscles. So I strongly suggest to use a visualizing method to inject one of these muscles. Okay, I'm sorry. Okay, just a short, sorry. Our main topic is cervical dystonia, but just a small clinical example of a patient with a focal hand dystonia. And especially in these kinds of movements, a treatment, especially of extensors, is really difficult, and the therapeutic window is very narrow. And this patient was injected into the extensor of the index and the middle finger, and this worked quite well. But you have to be very, very focal, and you can do this by EMG, of course, but it's quite easier to do this with ultrasound because you see what you're doing. Okay, here another clinical example. This is a patient with a writer's cramp. And you see, this is the non-treated hand, and I test the power of the end joints of the fingers. And you see there's normal power in the index and in the middle finger, and also in the long flexor of the thumb. And this patient was treated with a small amount of botulinum toxin into the long thumb flexor and the flexor of the index finger 3 months before. And you see there's still a paresis in the index finger, but there is no paresis in the middle finger. And this is what you intend to be very, very focal. Okay, and we treated the long flexor, and there's a paresis in the long flexor. Okay. Okay, but how to identify this muscle? So one thing which is possible in the arm, not possible in the neck, is to use active or passive movement of distinctive joints. What you see here is you have here the field of view for the ultrasound. What you see here, the radial artery, and you saw the pulsation of the radial artery here. Okay, and here you see the anatomy with the radial flexor. You see the superficial and the deep flexor of the fingers and the long flexor of the thumb. And what you can do is ask you do a passive movement of the thumb, and you in this way you can identify clearly the target muscle, which is quite easy and also possible with active movement. Typically in dystonia patients, if you're thinking about treating spasticity, active movement is typically not possible, but passive movement is always possible, and it's better to identify muscles. Coming to the, finger flexors. Again, you see the probe is moved a little bit more to the radial side, in green the superficial and the deep flexor, and you see the median nerve, the ulnar nerve and the ulnar artery, and the superficial part, the superficial flexor, and the deep part, the deep flexor. And now I'm searching for the index finger. And I asked the subject to move the end joint of the index finger. And what you see, there's a movement here, here, and here. It's really hard to say where is the end joint. What you have to do is to do a passive movement of the end joint. And then you see, okay, it moves here. And this is the deep flexor of the index finger. And afterwards, you look only at the superficial layer and do a passive movement of the whole finger. And what you see is it moves here. Okay, we're not looking at the deep one, but here. And this is the index finger, which is related to this part here of the muscle. Okay, then we move over to the middle finger. During an active movement, everything moves in the ultrasound picture. No chance of identification of a single muscle fascicle. Okay, okay, and then again, the passive movement of the end joint, it moves here. And then you do a passive movement of the whole finger. And what you see, there's a very huge movement here in the superficial part. And this is related to all this here. And this is very important to know that the organization of the flexors is from the radial side on. First muscle is the middle finger, the second is the index finger below, and then the ring finger and the little finger. And this crossing of fingers is very important to know for your treatment. For the deep flexor, everything is topographic, correct, index, middle, ring, and little finger. Okay. Another thing which is important for diagnostic in cervical dystonia is a differential diagnostic. And I saw this patient with a reduced range of motion in the neck since her childhood, and then she got operated. And after 20 years, the reduced range of motion was again present. And what you see, there is a structure here on this side. And the question to us was, is this a cervical dystonia? And I show you the video of the lady. She's not able to turn the head to the right. She's markedly reduced. And you see a very prominent structure here. And what you find doing an ultrasound is a fibrosis of the sternocleidomastoid, which was maybe happening during birth and was operated, and there's a secondary fibrosis of this muscle. And this is not a patient suffering where botulinum toxin helps. This is a patient who needs to be operated. And the second case, she had this lady became suffering from a shift to the right side, to the left side. No, a shift to the right and a tilted head to the left shoulder at the age of 15, which was a little bit surprising. So maybe she is suffering from cervical dystonia at a very young age. Typically, this occurs in the 40s and 50s, sometimes in the 30s. But in her in adolescence, this is quite unusual. And again, doing ultrasound in this young lady, we found a fibrosis of the sternocleidomastoid muscle. She's playing handball quite often, and maybe this is due to a trauma and the bleeding into the muscle, but this is not cervical dystonia and has not to be treated with botulinum toxin. So to summarize, I think diagnostic ultrasound helps in identification of muscle asymmetry, identification of tremor to some degree, but it's very helpful in the combination to using a combined approach with the EMG, so where you can be very sure in which muscle you are and say, okay, this muscle is involved in tremor, and you can identify other causes of head position anomalies. And for therapeutic approaches, it's very good to have especially for deep and small muscles. And the more you work on cervical dystonia, you will find involved muscles you want to treat, and you learn, using ultrasound, you learn a lot about anatomy. So a third point is that I think, from my approach, ultrasound changes your way of making concepts. about the involvement of muscles. So thank you very much from Lübeck. So this is our group here. And if you're interested in trainings for anatomy and ultrasound, you can write me an email. Thank you very much.
Okay, thank you, Tobias. And I would like to ask everybody, the attendees, if they have questions, please write them in the Q&A session.
Tanya, should I stop my...
No, you can leave your presentation.
Okay.
So here is the... Can you please show the last slide again?
Yes, I can.
Okay.
Should I go to the frequently?
No, this is the one. So I
Okay.
see what's incoming. Yeah, now. Okay, great. So another question is it possible to demonstrate how to localize OCI?
To demonstrate, yeah, possible in, so yeah, at the end it is possible, but it's really hard here in a presentation to demonstrate. I gave this, yeah, I have a, sorry, so where's this video? So this is the typical, so my hand is in before, the typical position of the probe is that the anterior border of the probe is in the near of the mastoid, and there's a 15-degree angle between processus transversus of C1 down to processus spinosus of C2. And then you have what you then get is this picture with the splenius, the semispinalis, and the OCI. But for someone who is a beginner in this topic, I think it's very helpful that there is someone who shows this really in real life with a subject and an ultrasound machine. And this is really hard to show just by a presentation, because it's a lot about eye and hand coordination and finding landmarks, how to orientate. Because there's another muscle above, which is the rectus capitis major, and this is a muscle doing a retro caput. And this looks quite similar. If you have a much steeper angle of the probe, like maybe 55 degree. So I'll go back here, speaking about the angle. Go back into this video. Okay, if you have an angle like this, then you see the same picture, but the deepest muscle is a different muscle with a complete different function. So at the end, yes, I can show you how I hold the probe, but to learn this, I think this is not possible by a presentation. I think it's better to do a training.
Okay, thank you. So we have other questions now. Can, without knowledge of ultrasound, do some short-term training at your center for USG-guided Botox treatment?
Yeah, we do this here. We do here trainings in Lübeck, which are maybe one-day courses, or if someone is interested in coming over here for a week and to see this. But at the end, if you would like to learn the injection itself, it's typically not allowed to do a patient treatment in a different hospital. So you have to do this in your own hospital. But to learning how we do this, you can come and visit us and maybe join us for a day or maybe for a week. We typically have guest doctors here every few months, and maybe for a week. It is possible, yes.
Okay, thank you. So then the next question is, how about ultrasound in enterocollis?
Yeah, Okay, I skipped this because, yeah, so what I do in anthrocolis, I typically treat the sternocleidomastoideus and the scalenus anterior. I do not show the sternocleido because it's obvious this is a very superficial muscle. The only thing you have to know is do not inject deeper than the muscle is. And I think this is the most often mistake, that maybe an injection of about 1 centimeter is too deep. But I inject the sternocleidomastoideus and I inject the scalenus anterior, typically at the first 2 muscles. If this does not help, I go for deeper muscles, which is the longus capitis and longus collis. And our approach to inject these muscles is via the mouth, with a local anesthesia by our ENT doctor. He's doing a local anesthesia and just a little pinprick, which is a very fast method. We do not do general anesthesia. I know there's an approach which is published from an English group to do this via ultrasound and pressing the carotid artery by the side in the injection from the front. I did this, but I find it very much easier to do this together with the ENT doctor, because via the mouth, this is a very superficial injection. You have to inject just 2 millimeters. If you're interested, I can show you a video, but I have to change the presentation. Sanja?
Yeah.
Yeah.
You just stop sharing that screen, and you have to first.
Okay.
Yeah. And now you can activate first what you now would like to show, and then start sharing again.
Okay. Okay. Just a few.
And in that time, because you were speaking about people coming to your institution, I would like for everybody to give the information that in the frame of the EJPRD project, there are possibilities to receive mobility fellowships. So for stays abroad from 2 weeks to 3 months, but you have to be affiliated to a so European Reference Network institution. But for further information, I will now put the link in the chat so everybody can get the full information, and if you are eligible, you can apply and receive that fellowship.
So, okay, I have the, so where is, okay, shares the screen, okay. Okay, so here you see a lady with a...
we don't see it, Tobias.
You don't see, so I forget
yeah.
to press share at the end. Okay, this is a lady with yes tremor. Sorry, I pressed the wrong button. Sorry.
Now we see
this
it.
slide. Yeah. I accidentally pressed. So you see this yes tremor. This is okay. And in this lady, we plan to inject the longus capitis, and this is maybe 8 years ago where I did it the first time, and there were no published data about this. So I tried it via doing ultrasound. This is a very old ultrasound machine. I'm sorry about this. This is filmed from the monitor, and here in the depth there's the antecollis. So this is another machine, and these are the 2 branches of the carotid artery, and this is the direction of the injection in this lady. So okay, here you see an artifact of the needle, which is hard to see, but and especially with all the tremor, and injected here. I did this 2 times, and 4 weeks later, she reported, okay, that the tremor was very much better, but the injection was a little bit unpleasant, and she reported swallowing problems. So I thought about what is about, and here you see an MRI, where is this muscle? And this is, the muscle is directly here in front of the the vertebral bones and becoming bigger and bigger if you go up and up. And when you see the throat, and there's a very, very tiny distance here. So what we did is we said, okay, maybe we can do local anesthesia and go here above the tongue and inject here. And this is exactly what our ENT doctor did. So, okay. Okay. And what you see now is, okay, and this is the procedure. This is just, beforehand there was a local anesthesia just by a spray, tuck, left and right, and that's it. Okay, that's so, and we did this now in, I think, in 7 patients, and we continue this only in, actually in 3 patients, because by the balance of side effects, which were mainly swallowing problems, the other 4 patients decided not to go on with this treatment. In 2 of them, and in 2 of them, this injection doesn't help. So this is our approach doing this treatment.
Okay, thank you. So there are some other questions. How are you injecting scalenus with ultrasound?
Okay, so this is the picture of the scalenus. So the probe is positioned here, and here, this is the anterior part, and here is anterior on this side. And what you see is the scalenus anterior here, and these branches of C5, C6, and C7 root of the plexus brachialis, and here is the scalenus medius. This is exactly the side where I inject. Typically, I bring the muscle directly in the middle of the ultrasound pictures for visualization of here of both muscles. This is it's shown like this, but I will bring the scalenus muscle in the middle of the picture and then directly inject above the probe here into the neck. Typically for the scalenus anterior, the muscle is the biggest muscle part is very much distal. It goes up and up to C3, C2, but in the upper parts, the muscle is typically very tiny. So I inject this maybe just 2 or 3 centimeters rostral from the clavicula.
Okay, thank you. Next question is, do you use ultrasound for oromandibular dystonia injections?
Only in rare cases where maybe the obliquus, maybe the omohyoideus is involved, because this is directly under, maybe I have it this in this presentation. I have some patients where I do this, but not for superficial muscles like maybe orbicularis oris or viseus zygomaticus. It could be interesting to do so, maybe for analyzing the thickness of the muscle, because the new ultrasound machine becomes so much better that that there could be an approach to do so. But actually, I use ultrasound only for the omohyoideus, which is below the carotid, below the sternocleidomastoideus and directly above the carotid artery. So I think it's impossible to inject in the upper part of the omohyoideus, impossible to inject without guidance.
Okay, thank you. And the very last question is how to avoid dysphagia with injection of sternocleidomastoid?
Yeah, so if you are speaking with different people doing botulinum toxin treatment or looking at how they perform, then you see that there are a lot of different approaches of where to inject, how deep. And in my experience, or what I think, is that swallowing problems are due to in injecting which is not targeted in the sternocleidomastoids, but too deep. And if you go very much to the mastoid, then, and you inject maybe in 1.5 centimeters, you can reach the venter posterior of the digastricus muscle. Or if you go down, then into the infrahumeral muscles. So I think it's very important to inject superficial enough and to avoid to inject too deep.
Okay, so this was the last question.
Okay.
So thank you
very
everybody.
much.
And we can stop the webinar now. Thank you everybody, and hope to see you on our next webinar in 2 weeks. Thank you, Tobias.
Thank
and
you.
bye bye
Sanja.
everybody.
Bye.